This conference will now be recorded.
So today our topic is on acute rheumatic fever. I hope this topic is already covered and you are very well versed, because this is also a topic that is dealt in even in general medicine also. The same old saying is there, like rheumatic fever, it licks the joints and bites the heart. This is like old saying. So mainly it affects cardiac system. Cardiac component will be there in acute rheumatic fever. So coming to a brief introduction part, acute rheumatic fever is a systemic disease of childhood, often recurrent, that follows a group A beta hemolytic streptococcal infection. So it is a diffuse inflammatory disease of connective tissue, primarily involving heart, blood vessels, joints, subcutaneous tissue, and even central nervous system. Why this predilection to these particular tissues are like molecular mimicry between this group A beta hemolytic streptococcal infection with particular serotypes, along with the concerned tissues that we are given, like heart, blood vessels, and joints, and subcutaneous tissue, and so on. See, coming to the first of all etiology part, like there is a link between, till now we discussed like group A streptococcal upper pharyngitis infections and acute rheumatic fever as well as rheumatic heart disease. Because why? 2/3 of patients with an acute episode of rheumatic fever usually have a history of upper respiratory tract infection several weeks before. Almost in 2/3 of cases, we can appreciate this history. Coming to the age, the peak age is around 5 to 15 years of age group. It is unlikely in less than 5 years of age group, because 5 years are like mostly school age group that comes to coming out of the house and within the community. So age group is more of like 5 to 15 years of age. And also one more important thing is like seasonal incidence of this acute rheumatic fever almost closely parallel with that of group A streptococcal pharyngitis. And one more important thing is usually these patients with acute rheumatic fever almost always have a serological evidence of recent group A streptococcal infection. I'm insisting on this part of group A streptococcal infection because there is some link. There is a immuno-mediated injury, because immediately after infection we don't get this phenomena of acute rheumatic fever. There is a time gap or latency period to happen this because of the pathogenesis that is occurring because of this infection called as group A streptococcal infection. And also it is rarely seen in less than 3 years of age. Girls are most commonly affected than boys. Common in third world countries. Usually environmental factors like overcrowding, poor sanitation, poverty contributes to increase in this particular entity. This is a bit on epidemiology, and you also should know, like not every serotype of group A streptococcal infection can cause rheumatic fever. Some strains, particularly M type 4, caused acute pharyngitis in a very susceptible rheumatic population. But still no recurrences of rheumatic fever occur with type type 4. But in contrast, episodes of pharyngitis caused by other serotypes in same population lead to frequent recurrences of acute rheumatic fever. So this is not a single episode entity. We may expect some recurrences, sometimes recurrences of this acute rheumatic fever. That acute rheumatic fever recurrences depending upon the type of serotype which it is causing. Usually the serotype M type 4 we are discussing in group A streptococcal infection usually have no recurrence. So obviously this is the point telling the rheumatogenicy of the particular serotype of group A streptococcal infection causing this disease, that you should know. And one more thing, for suppose this group A streptococcal infection associated with the skin infection rarely causes recurrences of rheumatic fever with a previous history of rheumatic fever or first episode of rheumatic fever. So not all the group A streptococcal infection causes this acute rheumatic fever. Causing pharyngitis serotypes has more predilection to cause rheumatic fever, and also there are several subtypes that causes even recurrences of this acute rheumatic fever. So what are the most commonly identified serotypes that you should know are like M type 1, 3, 5, 6, 18 and 29. You cannot remember every serotype, so just you have to know there are different serotypes. Each serotype will have a particular entity of causing either pharyngitis or skin infections. You should know what serotypes causes pharyngitis because that has more predilection to get acute rheumatic fever. So this is brief regarding epidemiology. Coming to the pathogenesis part. So this is not directly an entity or infectious thing because immediately after the infection we won't get any disease like immediately after that we will not get. So there is obviously we can appreciate some immune response to infection with group A beta hemolytic streptococcal infection. So there is a major obstacle to understand the pathogenesis of acute rheumatic fever and rheumatic heart disease. Why? Because there has not been any established animal model, but several theories are proposed to explain the pathogenesis of acute rheumatic fever. One is cytotoxicity theory, another one is immunological theory. The mostly accepted theory is immunological theory. What happens exactly in immunological theory is like an immune mediated pathogenesis for acute rheumatic fever is like there is a latent period between group A streptococcal infection and acute rheumatic fever. What happens is the antigenicity of several group A streptococcal cellular and extracellular epitopes and their immunological cross reactivity. So there is having a potential cross reactivity with this particular infection with cardiac antigen epitopes. Also supports the hypothesis of molecular mimicry. So there is a common molecular mimicry between the group A streptococcal antigens as well as cardiac epitopes or antigens. So there are common epitopes shared between group A streptococcal components. For example, M protein, cell membrane, and group A cell wall carbohydrate, capsular hyaluronate, and specific mammalian tissues. With what this molecular mimicry is happening is like heart valves, brain and joints. That's why they have more predilection to these particular tissues involving. For example, they share usually the epitopes with human myocardial proteins such as tropomyosin and myosin. So that's why they damage particularly those tissues resulting. So this is like immunological mediated injury because of the same molecular mimicry, and this is the most accepted theory. Why? Because we are also having given a latent period of 1 to 3 weeks. It is not a directly infection news damage. So you should know this part in pathogenesis. So I already discussed what are the types that produce rheumatic fever: M type 1, 3, 5, 6, 18 and 24. These causes acute pharyngitis. Sorry, acute pharyngitis with also having more of recurrences chances. Skin infection produced by group A beta hemolytic streptococcal infection leads to post-streptococcal glomerulonephritis only. It will not result in rheumatic fever or carditis. So this is the diagrammatic structure of group A beta hemolytic streptococcus. You should know what are the parts it is having, like capsule, cell wall, protein antigens, group carbohydrate, peptidoglycan, because all this will be like molecular mimicry because they share same molecular mimicry with the heart valves, joints, some parts of basal ganglia in central nervous system, and also subcutaneous tissue. So one more theory, till now the most accepted theory we discussed is immune mediated pathogenesis. I already explained this thing. One more thing is cytotoxic theory, where the enzymes produced by group A beta hemolytic streptococci like streptolysin O causes tissue damage. This is not much explained theory because major problem with the cytotoxicity hypothesis is its inability to explain the substantial latent period. Why? between group A streptococcal pharyngitis and onset of acute fever cannot be explained by this cytotoxic theory. So that's why the most proposed theory is immune mediated pathogenesis, and we already discussed briefly on this part. So this is the thing happening, streptococcal infection by group A beta hemolytic streptococcal infection causing sore throat followed by immune response resulting in cross reactivity because of the molecular mimicry resulting in acute rheumatic fever. Rheumatic fever, the carditis could be like myocarditis or pericarditis or endocarditis. If anything can be there, can happen. And endocarditis is most common, resulting in aortic regurgitations and mitral regurgitations. So I just want to first of all to tell you the revised Jones criteria under the manifestations. Then we will go in detail with the clinical manifestations of the topic. So initially, when this Jones criteria came into picture is like in 1944, but the Jones criteria is revised in 2015. So this is the newest revision by on 2015 by American Heart Association for the diagnosis of initial attack of acute rheumatic fever as well as recurrent attacks. You should know both the things. There are 5 major criteria and 4 minor criteria and a requirement of evidence of recent group A streptococcal infection. And one more thing, what is new in this 2015 revision is it includes a separate criteria for a low risk population as well as a high risk population. So you must know what is a low risk population, what is a high risk population. See, low risk is, it is defined as those with incidence of less than 2 per 1 lakh school age children per year or all age rheumatic heart disease prevalence of less than 1 per 1000 population, that we call it as low risk. So incidence should be less than 2 per 1 lakh or prevalence of less than 1 per 1000, then only we call it as low risk population. So anything deviation from this, we call it as a high risk population. Why we categorized? Because there are some set of criteria particularly we give for low risk and high risk population, high risk or moderately risk population even. So you have to know the criteria for a low risk population is like carditis, arthritis. In low risk population, we consider only polyarthritis as major criteria, chorea, erythema marginatum, and subcutaneous nodules. We'll be discussing in detail in the further part of your class. And minor criteria in a low risk population, we include polyarthralgia, hyperpyrexia of more than 38.5 degrees centigrade, ESR of more than 60 mm per hour or CRP of more than 3 mg per deciliter, prolonged PR interval. Coming to the high risk population, the same thing, all the 5 major criteria will be same in both the low and high risk. What is important in this? Even monoarthritis we consider in a high risk population. Only polyarthritis we take it as a criteria in low risk population. So high risk, there is chances of getting acute rheumatic fever is more. So we are decreasing our threshold. So even a monoarthritis, we consider it as a major criteria. Coming to your high risk population, even monoarthralgia we can consider in a minor criteria. Temperature need not be like 38.5. We cut it down at 38 degrees. ESR of more than 30 and CRP of more than 3. Prolonged PR interval according to the age. This is same. So these are the differences. One is arthritis, another one is arthralgia, another one is temperature, one more thing is ESR. So you should know the criteria which was revised in 2015 by American Heart Association depending upon low and high risk populations. And you also should know what is a low risk population. Depending upon the incidence and prevalence, we call it as a low risk. Incidence of less than 1 per 1 lakh less than 2 per 1 lakh population and prevalence of less than 1 per 1000, we call it as low risk population. So this is the thing I already discussed. What is a low risk? Instance of less than 2 per 1 lakh school age children per year or all age rheumatic heart disease prevalence, because prevalence is like both old and new cases of less than 1 per 1000 population. Those with higher incidence or prevalence rate, we call it as moderate or high risk population. So according to the Jones revised criteria for the guidance in diagnosis of rheumatic fever, you have to know whether to diagnose whether it is a first attack or do diagnosis of a recurrent acute attack. For the first attack, two major manifestations or one major and two minor manifestations plus an evidence of recent group A streptococcal infection. Coming to the diagnosis of recurrent acute rheumatic fever, two major or one major and two minor plus evidence of group A streptococcal infection or three minor manifestations in moderate or high risk population. So even three minor in a moderate or high risk populations, we should consider to treat it as a or diagnose it as a recurrent acute rheumatic fever. Anyway, evidence of recent group A streptococcal infection of supporting evidence should be there. So this is the entity. So you must know for diagnosing a first attack or recurrent, there are same criteria along with three minor manifestation plus evidence of recent group A streptococcal infection in a moderate or high risk population you must consider. So coming to clinical manifestations, these are nothing but the clinical manifestations that are present in your major criteria. Like polyarthritis, it occurs in almost 75% of patients with acute rheumatic fever. In the initial slide of my class, I already told you, it licks the joints and bites the heart. So it automatically, even it affects the joints, it will be like subsiding or healing with no residual deformity to the joints will be there. So first of all, we'll discuss with arthritis, then we'll come with the carditis. Arthritis occurs in approximately 75% of patients. It typically involves the larger joints, particularly the knee, ankle, wrist, and elbow. Involvement of spine, small joints of the hands and feet or hips is uncommon. Rheumatic joints are classically hot, red, swollen, and tender, with even the friction of bedclothes being uncomfortable. So the patient will be having severe pain and uncomfortable. The pain can precede and can appear to be disproportionate to the objective findings. The objective findings we see is disproportionate to the complaints by the child or the patient. So the joint involvement is characteristically migratory in nature. That is, severely inflamed joint can be normal within 1 to 3 days without any treatment, even as one or more other large joints become involved. Severe arthritis can persist for several weeks in untreated patients. So here one important thing you must remember, arthritis involving the larger joints, spine and smaller joints are less commonly involved. The joints are like typically red, hot and swollen, and the patient will be having utmost discomfort disproportionate to your objective findings. The pain is migratory in nature. What do you mean by exactly migratory? Today we see the joint swelling in a knee. After 1 to 3 days, that particular joint is completely subsiding on its own without any residual deformity or anything. Another new more joint is involved at that point of time. So this is a typical of rheumatic fever. And one more thing, it has a tremendous response to salicylates. That's why we'll withhold the treatment with salicylates to see this migratory nature of rheumatic fever. Usually the absence of response to this particular drug of salicylates, we have to think of another alternative diagnosis apart from your rheumatic fever. So what will we see when we aspirate? If at all, if we aspirate, what will you see in synovial fluid? Usually had blood cells of 10,000 to 1 lakh, predominance of neutrophils, and usually a protein level of 4 gram per deciliter and a normal glucose level. Frequently, arthritis is the earliest manifestation of acute rheumatic fever and may correlate temporally with peak anti-streptococcal antibody titers. There is a often relationship between severity of arthritis and cardiac involvement, which is inverse. So the more severely the joints are involved, the less the cardiac involvement. This inverse relationship you must know. Usually arthritis and Sydenham's chorea also can never occur simultaneously. So these are the points you have to remember in your arthritis part, usually the polyarthritis. Next, coming to your second criteria, that is carditis. So one more thing in your revised Jones criteria of carditis I should explain here is like subclinical carditis. You must know what do you mean by subclinical carditis. So it is defined as without a murmur of valvulitis, but with echocardiographic evidence of valvulitis. So whenever you're examining a case, if you doesn't find any murmur or any suggestive features of valvulitis, but still your echocardiography showing the picture of valvulitis, you call it as subclinical carditis, and you have to take this also consideration as your major criteria. We'll be discussing the later what will be there in those things. But usually almost always associated with a murmur of valvulitis. In universal finding rheumatic carditis, whereas the presence of pericarditis or myocarditis is variable. What are the valves most commonly involved is mitral valve, followed by aortic valve of 20 to 25%. If in the mitral regurgitation, you characteristically hear a high-pitched apical holosystolic murmur radiating to the axilla. In aortic insufficiency or aortic regurgitation, it is characterized by a high-pitched decrescendo diastolic murmur at the left sternal border. We already discussed carditis occurs approximately in 50 to 60% of cases of acute rheumatic fever. And recurrent attacks of acute rheumatic fever in patients who had carditis with their initial attack are associated with higher rates of carditis with increasing severity of carditis in further recurrent attacks. So these are all the things we already discussed. So severe mitral regurgitation could be due to valvulitis or mitral annular dilatation, caudal rupture, leaflet prolapse with or without caudal elongation. Pericarditis is only 6 to 15%, very less likely. It is usually diagnosed by typical pain and friction rub, always associated with a rheumatic valvulitis, may be associated with a normal ECG, may be associated with effusion, but rarely causes any constriction or a tamponade. Its presence denotes usually a severe entity of carditis. So you must know, till now I already told you what you mean by subclinical carditis. You couldn't appreciate any murmur, but echocardiography shows some set of findings where pathological mitral regurgitation and pathological aortic regurgitation seen at least in two views, jet length of more than 2 cm in at least one view in pathological mitral regurgitation, jet length of, if at all it is more than 1 cm in one view in aortic regurgitation, peak velocity of more than 3 meters per second either of mitral or aortic regurgitation, pansystolic jet in at least one envelope. So these are the echocardiographic findings you could appreciate even a subclinical carditis when the patient is not having any clinically appreciated murmur. Endocarditis is almost an universal finding in rheumatic carditis, whereas the presence of pericarditis or myocarditis is variable. Valvular insufficiency is characteristic of both acute and convalescent stages of acute rheumatic fever, whereas mitral and aortic valve stenosis usually appear years or even decades after the acute illness. Already we discussed polyarthritis. Next one is your subcutaneous nodules. It is usually rare. Less than 1% with acute rheumatic fever, maximum of 2 to 20%. Findings are like consistency with firm nodules approximately 1 cm in diameter along with extensor surfaces of tendons near bony prominences. There is a correlation between presence of these nodules and a significant rheumatic heart disease. These are subcutaneous nodules. Coming to the erythema marginatum, it is a rare but characteristic rash of acute rheumatic fever. Consists of erythematous serpiginous macular lesions with a pale centers which are never pruritic. So the child will never have a complaint of itching. So non-pruritic. It primarily occur on trunk and extremities but not on the face. So you can never appreciate these lesions on face. And one more thing, these are never itchy. Usually the center will be pale. And one more important point, it can be accentuated by warming the skin. So this is the picture of erythema marginati. You can appreciate on extremities and as well as on trunk, never on face. Coming to your last major criteria, that is chorea. 10 to 15% of patients. Isolated, frequently subtle movement disorder. Emotional liability, incoordination, poor school performance, uncontrollable movements and facial grimacing you can observe. Chorea sometimes it is like unilateral, that is called as hemichorea. Usually the latent period between group A streptococcal infection and the manifestation of chorea is very much long and can occur after months. So clinical maneuvers that helps in detecting this is milkmaid's grip. These are all like clinical entities. Spooning and pronation of hands when the patient's arms are extended, and examination of handwriting to evaluate the fine motor movements. One more thing, diagnosis is based on clinical findings with supportive evidence of group A streptococcal infection. Because we already discussed, there is a long latency period between group A streptococcal infection and occurrence of this onset of chorea. So by that time, the antibodies may be normal. So there will be never a correlation between the peak rise of group A streptococcal antibodies with the chorea because of this long latency period. So that should not be included in your criteria to diagnose it as a chorea. So mostly it is like clinical. And one more thing, it is exaggerated by stress and disappears with sleep. Rheumatic chorea, marker of future carditis. Chorea is rarely associated with polyarthritis. Inflammatory markers and ASO titers may be normal because of the long latency period. We already discussed that entity minor criteria, which is differs both in high risk population and low risk population. I already discussed those entities. So next is evidence of group A streptococcal infection. So supporting evidence for antecedent group A streptococcal infection, scarlet fever, positive throat culture, rapid streptococcal antigen test, elevated or rising streptococcal antibody titer, that is ASO or anti-DNase B and anti-hyaluronic acid. So I know this is a boring and somewhat bit exhausting class. I do accept. Till now we discussed what is the basic brief introduction, epidemiology part and pathogenesis part, followed by your major and minor criteria, low and high risk population, and what are the differences that exist in minor criteria and major criteria in both high and low risk population, along with the antecedent evidence of recent group A streptococcal infection. So coming to your differential diagnosis part, you should know for each and every component the differential diagnosis. So some of the differential diagnosis entities, just I'll read out the names. For arthritis, juvenile idiopathic arthritis, reactive arthritis, serum sickness, sickle cell disease, systemic lupus erythematosus, Lyme's disease, pyogenic arthritis, and post-streptococcal reactive arthritis, because arthritis can be seen in all these conditions. Carditis can be seen in viral myocarditis, pericarditis, infective endocarditis, Kawasaki disease, mitral valve prolapse, innocent murmurs, and congenital heart disease. Chorea can be seen in Huntington's chorea, Wilson's disease, cerebral palsy, tic disorder, and hyperactivity. See, differential diagnosis is nothing but closely related to our particular diagnosis, what we are dealing or what we are diagnosing. For an acute rheumatic fever, any disease, it is like a constellation of all the symptoms or all the clinical findings, all the physical findings, and put together to have a particular or narrowing the diagnosis. So once we are narrowing all these diagnoses, we have to be cautious regarding all the diagnoses, how we can exclude. So till now, we can include, like what are the criteria. That's why for every particular disease there are particular entities, not only single entity. We have to club all these things. So coming to your treatment part, so all the patients with acute rheumatic fever should be placed on bed rest and monitored closely for evidence of carditis. They can be allowed to ambulate when the sites of acute inflammation are subsided. However, patients with the carditis require prolonged periods of bed rest. This is not strictly for all the patients, only with evidence of carditis. So next, your antibiotic therapy. Usually once the diagnosis of acute rheumatic fever is established, regardless of your throat cultures, the patient should receive 10 days of orally administered penicillin or amoxicillin or a single intramuscular dose of benzathine penicillin, and should be continued lifelong depending upon the clinical features. We'll come in later on those topic in the next few slides in a few minutes. Next, one more thing I already discussed, polyarthritis tremendously responds to your salicylates, that is aspirin. The dose of 50 to 70 mg per kg per day in divided doses for 3 to 5 days, followed by 3 weeks, followed by half the dose for another 2 to 4 weeks. So patients with typical polyarthritis and those with carditis without any cardiomegaly or congestive cardiac failure should be treated with oral salicylate. So when we we're going to give this is like in polyarthritis as well as with the carditis, but without any evidence of congestive cardiac failure. So carditis alone, aspirin is sufficient. Carditis with cardiomegaly, also aspirin is sufficient. When congestive cardiac failure is there, you have to give your steroids. That is prednisolone. Usual dose of 2 mg per kg per day in 4 divided doses at least of 2 weeks, followed by half dose, that is tapering, for another 2 to 3 weeks, and tapering of dose by 5 mg, that is 5 mg in a 24 hours every 2 to 3 days. So once we are planning to taper the steroids, we have to add your aspirin to prevent rebound inflammation. So carditis with congestive cardiac failure, any time with congestive cardiac failure, we start treating with steroids. Once we start with steroids, at their tapering end, we have to again restart your aspirin to prevent any rebound inflammation. So aspirin at what dose we need to start? That is, previously we discussed the same dose, 50 mg per kg per day in a 4 divided doses for 6 weeks to prevent rebound inflammation. Sometimes, like preventive measures, sometimes in congestive cardiac failure, we may require even diuretics, digitalis, fluid and salt restrictions, strict bed rest, and oxygen supplementation along with low salt diet is even required. So sometimes what happens is, like when we terminate all this inflammatory therapy, it has following the reappearance of the clinical manifestation or of elevated ESR and C-reactive protein. So we have to increase our doses again till all those levels are getting normal, to get normalized. That is the entity. So chorea, we already know that chorea often occurs as an isolated manifestation after the resolution of acute phase of the disease. So usually this have the long latency period. So in this particular entity, I don't think we have to give any anti-inflammatory agents. So anti-inflammatory agents are not needed in chorea. So this is a movement disorder. Sedatives may be helpful in the early course of disease. The drug usually effective is phenobarbital. If at all phenobarbital is ineffective, then we go with haloperidol, that is antipsychotic, 0.01 to 0.03 mg per kg per day in 2 divided doses orally, or chlorpromazine 0.5 mg per kg every in 4 divided doses orally. Some patients may benefit from few week course of corticosteroids. The benefits are not known properly. So you must know, usually anti-inflammatory we don't give. The drugs we give are like phenobarbital and haloperidol. You need not remember your dosages, just for information purpose. So anti-streptococcal regimen. So drug of choice, phenoxymethylpenicillin orally, benzyl penicillin intramuscularly. Usually intramuscularly, body weight of more than 40 kilos, we give 1.2 million international units. Less than 40 kilos, 6 lakh international units. Primary prophylaxis. You must know what do you mean by primary prevention. See, before the 9th day of symptoms of acute group A streptococcal infection, pharyngitis. So in primary prophylaxis, in primary prevention, the patient with pharyngitis only we are treating with antibiotics. There is no chance of getting acute rheumatic fever, or we have to stop even the first attack of acute rheumatic fever. That is your aim of primary prevention. So in primary prevention, the child will not, we have to aim the child should not get acute rheumatic fever. This is highly unlikely because acute group A streptococcal infections, we don't, if we are not in that thing, we don't even recall that episode of pharyngitis or sore throat. So that is difficult to implement. For suppose, if at all, if you give that primary prevention, the dose is less than 27 kilos, single dose of IM benzathine penicillin of 6 lakh, more than 27 kilos, IM benzathine penicillin of 1.2 lakh. Oral, the drugs are penicillin, erythromycin, first generation cephalosporin, or azithromycin. The rest of the 3 drugs we give for 10 days. Azithromycin we give for 5 days. So secondary prophylaxis. In secondary prevention, what is directed at preventing acute group A streptococcal pharyngitis in patients at substantial risk of recurrent rheumatic fever. So already rheumatic fever had occurred. We are preventing the recurrences. So we are continuing antibiotic prophylaxis. which should begin as soon as when you diagnosed as rheumatic fever, you have to give your prophylaxis only to prevent further episode or further recurrences, not to modify this present episode. And one more thing we already discussed, patients who is having carditis is a potential to develop recurrences. So they have to give long-term antibiotic prophylaxis, usually lifelong. So depending upon the carditis entity, we divide like rheumatic fever without carditis, no carditis, only rheumatic fever at least of 5 years or until 21 years of age. Rheumatic fever with carditis 10 years or until 21 years of age, whichever is longer. With carditis and residual heart disease also there, which requires lifetime prophylaxis. So why? Because with carditis the recurrences are more. So when the child is having carditis with acute rheumatic fever, we continue our prophylaxis a bit longer. Without any carditis, 5 years or 21 years, which is longer. With carditis without any residual heart disease, 10 years or 21 years, whichever is longer. Usually with residual heart disease, we give lifelong prophylaxis or till the age of 40 years, whichever is longer. So you have to know, in primary prophylaxis, we are preventing the child of getting acute rheumatic fever. In secondary prophylaxis, we are preventing the child to have recurrences of acute rheumatic fever. Already the child had one episode of acute rheumatic fever. So the drugs, the same thing. Benzethine penicillin, less than 27 kilos, 6 lakh international units, more than 27 kilos, 1.2 million international units. Route is IM. The other drugs is penicillin V, 250 milligram twice a day orally. Sulfadioxine or sulfazoxole, the dose is 0.5 gram for less than 27 kilos, 1 gram for more than 27 kilos on oral. But we preferably give benzethine penicillin. So prognosis, before antibiotic prophylaxis, 75% patients develop recurrences and residual heart diseases. 50 to 70% with carditis during initial episode recover with no residual disease. Severe the initial attack, more chances of rheumatic heart disease. Risk of recurrence is more in first 5 years of initial episode. 20% of patients with pure chorea, not given secondary prophylaxis, develop rheumatic heart disease within 20 years. So you must know some part on prognosis to explain the patient. So whenever the initial episode is associated with carditis, the risk of recurrences will be very much more. So you have to even counsel the patients in that way. And also it is there clearly, even though carditis is there and there will be chance of having recurrences, but one better thing is, even with 50 to 70% of patients with carditis during initial episode usually recurs with no residual disease. This is only happening or happy entity. But the more the severe the initial cardiac involvement, even the first episode of cardiac involvement is like very severe, the recurrent attacks, the residual heart disease will be more likely. Patients without carditis during the initial episode are less likely to have carditis with recurrent attacks. So one important thing, no carditis, better outcome. Even with carditis, 50 to 70% will recover with no residual disease. But the carditis is severe during the initial episode, more chances of developing rheumatic heart disease with a permanent valve damage. That is more. Patients who have had acute rheumatic fever are susceptible to recurrent attacks following reinfection of upper respiratory tract with group A streptococcal infection, with approximately 50% of risk with each group A streptococcal pharyngitis. So that's why, because once attack is there, further infection will aggravate the already prone condition. That's why we continue long-term chemoprophylaxis. Usually before antibiotic prophylaxis was there, usually 75% of patients had initial episode of rheumatic fever, had one or more recurrences. Now this rate has came down because if you are effectively implementing antibiotic therapy. And these recurrences are most common causes of your morbidity and mortality. The risk of recurrence is highest in the first 5 years after your initial episode, and usually decreases with the time. So when the recurrence is not within 5 years, then it is somewhat safe, because recurrence risk is more in first 5 years of initial episode. 20% of patients who present with pure chorea who are not given secondary prophylaxis develop rheumatic heart disease within 20 years. So therefore, patients with chorea, even in the absence of other manifestations of rheumatic fever, require long-term antibiotic prophylaxis. So one must know, even for a chorea, if at all no other criteria, only even chorea also we can diagnose acute rheumatic fever sometimes. Even with the single entity of chorea also, we need to give lifelong prophylaxis in this acute rheumatic fever. Till now I didn't ask any questions. Now I am going to ask something. Am I clear? Any doubts you may ask now. Any doubts? Are you there? Any doubts? Roll number 69. Am I audible?
Yes, ma'am.
Okay. Any doubts?
No, ma'am.
So someone tell me what are the things that are there in major criteria, because time is there. Everyone gave your attendance?